Alright, 8:30 already. We shall start. Okay, I'm Dr. Faiz. I'm the pediatrician and the cardio unit. So today we're going to talk about rheumatic disease in childhood. So it's involve rheumatology and cardiology lah, mostly the disease in this topic. Alright. Okay, so the outline of presentation today is how we obtain history, how we examine in patient with rheumatic disease, the differential diagnosis involved, and then the useful and the relevant investigation, and then we're going to talk about common rheumatic disease in childhood. Okay, so the general approach to joint pain in children, as usual, 80% is history, the rest is examination. Then we're going to come up with our differential diagnosis and what investigation we're going to order. Alright, so the history, as usual, the pain. Where's the pain? Your usual history using the Socrates or whatever mnemonic you are using. Then the swelling. As usual, if you got joint pain, there will be swelling. Some will have no swelling if very mild. The morning stiffness. This indicate the typical rheumatological problem like your JIA, your dermatomyositis. Okay, and then the weakness as well. In dermatomyositis, they will have weakness. Or patient have muscular dystrophy, they will have weakness as well. Or heel pain, if patient have some type of plantar fasciitis. Alright, then the history that the pain history that you're going to take is the quality of the pain. If any rashes indicate certain diagnosis like your JIA, your SLE, dermatomyositis, your scleroderma as well. Alright. The weight loss indicates, and weight loss fatigue indicate the systemic involvement. So most likely is your JIA, SLE. Alright. Any GI symptoms? So if got diarrhea, constipation, diarrhea, so your inflammatory bowel disease also will have symptoms like joint pain. So you have to ask about GI symptoms. Any vision problems? If involve if there is uveitis, there is some eye symptoms like eye redness, eye pain. That one including your JIA, including your SLE as well. Ulcers, indicative more of SLE, and dysuria. Okay, so dysuria indicate if there is involvement of your kidney, like in glomerulonephritis. Alright, so history of activity. If activity is affected, the disease is active and the disease is quite moderate to severe. As asthma as well, your school day loss, if any skipping school absentees, and any sleep disturb. Alright, so for the history I'm going to take is the family history. If there is family history of joint pain, the family history of psoriasis, IBD, and joint pain, SLE in the family, or any other autoimmune disease lah. Alright, and CT is connective tissue disease. So more history on travel. So travel is patient travel to US, for example, or any Western countries. Lyme disease is quite common over there. So Lyme disease will have joint pain. TB, any problem involving any organ, you have to think about TB. So TB is still part of your differential diagnosis involving any system. Okay, and then trauma, this one no brainer. Okay, medication, certain medication will have joint pain as a side effect. For example, your chemotherapy drugs, your anticonvulsant, certain antibiotics like ciprofloxacin. Okay, so the physical examination, the need to do full general examination. On the joint specific examination, you examine for the heat, any swelling, then you examine the joint range of passive and active motion, any tenderness or any deformity. Deformity could be fixed flexion deformity or partial flexion deformity. Okay, so this also include the bony tenderness, the spine tenderness, sacroiliac joint. Your enthesis is basically the insertion or origin part of your ligament or tendon. Okay, and then on top of it, you need to examine the leg length discrepancy as well, if any. Okay, so gait also important in rheumato examination or in neuro examination. Most of the time, it's best to do the gait first. so that you can see the gait and then narrow down your differential diagnosis based on the gait. Okay, if walking on heels, if patient unable to walk on heels, that indicate cerebral palsy, certain joint problem. On toes as well, patient on CP, if patient have muscular dystrophy, they are unable to walk on toes. And then you examine if patient able to stand on one foot or not. Okay, this one indicate any hip stability, hip instability lah, if a patient unable to stand on one foot. Gowers test, can anybody tell me what about Gowers test to diagnose what problem? Duchenne, yeah. So in Duchenne they have proximal myopathy, so the proximal muscle is weak, so they have to use the hand to support their weight, and then to basically to stand lah from the sitting position. We examine the muscle bulk, if there is muscle wasting, and also the strength. Okay, these are the symptoms that can be present in patient with rheumatic disease. First, we talk about fevers. If patient have fevers, especially very prolonged fevers, you have to think about systemic JIA. JIA is juvenile idiopathic arthritis, SLE, if any vasculitis. So very important about rheumatic fever. If patient have rheumatic fever, either predisposed with previous history of sore throat or skin diseases. Okay, sarcoidosis. Sarcoid mean basically granuloma formation in organ. So sarcoidosis basically disease involving your granuloma formation in the organ, especially your lung and then your lymph node. MCTD is mixed connective tissue disease. Okay, so any other possible non-rheumatic disease with the same fever presentation include your melanesis, your IBD, your Kawasaki, then your HSP lah, which is your Hinox-Schönlein purpura. Arthralgia is a symptoms. Basically, what is the difference between arthralgia and arthritis? Arthralgia is what the patient complain. Basically, it's just joint pain. Arthritis is disease or sign of any sign of swelling and all that is we say is arthritis. Okay, so if got arthralgia, JIA, SLE, rheumatic fever, and juvenile dermatomyositis, scleroderma and scoliosis, they will all have joint pain as the primary symptoms. Okay, some other differential you have to entertain. You have to remember the hypothyroid, the trauma, infective endocarditis, and others as well. Okay, weakness is more in juvenile dermatomyositis if there is myositis secondary to SLE or in mixed connective tissue disease, and very deep localized scleroderma. Okay, so if got weakness, we have to think about Duchenne, Beckett's like in the muscular dystrophy, and any other metabolic syndrome or myopathies. On top of it, don't forget your hypothyroidism lah. Alright, so hypothyroid also can present with proximal myopathy as well. Alright, so for chest pain, if chest pain, the symptom can be present in your juvenile rheumatoid arthritis, SLE, especially involving your pericardium and pleura. So pericardium is pointing to pericarditis and costochondritis lah. Your rib also have joint, so any joint inflammation over there will be called costochondritis. Okay, so back pain is pointing to your vertebrae and the joint over there, your spondyloarthropathy or juvenile ankylosing spondylitis. Don't forget the compression fracture, inflammation of the discitis, or any tumor involving your vertebrae or spinal cord. And then spondylolysis is basically the inflammatory process causing the vertebrae to be collapsed. Spondylolisthesis basically the joint displacement lah, mean it's bit displaced compared to the normal position, and any bone marrow occupying lesion. Alright, and osteomyelitis. Alright, fatigue is systemic symptom, so it can be anything, but in rheumatoid disease is SLE, juvenile dermatomyositis, and mixed connective tissue disease, your vasculitis, and then your JIA. Alright, so for sign, for malar rash is very specific to your SLE and juvenile dermatomyositis. So SLE usually spare your nasolabial fold, but non-rheumatic causes that will have rash, including your sunburn, your slap cheek disease, which is your parvovirus B19. On top of it also, don't forget the Kawasaki. Oral ulcer is pointing to your SLE and Behçet. Behçet also have genital ulcer. Also can be present in HSV, humans herpes simplex virus, and this PFAPA. Alright. Okay, purpurate rash is pointing to your vasculitis, for example your HSP, and could be also your Wegener granulomatosis lah. There is a triad of it lah, including your AGN, the vessel problem, and another one I can't remember. Alright. Okay, HSP typically start from small lesion on the lower extremities and the buttock, and later on they become bigger and then they coalesce. Alright. So purpurate rashes is patient very septic, is meningococcemia. So this one very high mortality rate. So have to recognize them early and treat them early. And then on top of it, thrombocytopenia will present with all these PTK, small PTK, but the big bleeding, the massive bleeding will have purpura, okay, or any clotting disorders. Alright. So Gottron papules is specific to the juvenile dermatomyositis. This one we will see the images later. So GDM will have heliotrope rash basically around your eyes, and then on top of it your psoriasis and eczema as well will have Gottron papules. Alright, for arthritis, if any sign of arthritis, if there is joint swelling, joint deformity, so it's JIA, spondyloarthropathy, SLE, all the things that we have mentioned previously. Okay, so chronic swelling for more than 6 weeks required the diagnosis of chronic arthritis of childhood, including your mixed connective tissue disease. They have also diffuse puffiness of the hand. Some other differential as listed here lah, mostly post-viral arthritis, reactive arthritis, Lyme disease, Kawasaki, and malignancies. Okay, so what investigation you want to send? You send your FBC to look for any sign of infection. Albumin, the patient is severe disease, your albumin will be low, and then you send your LFT. CPK will be raised in your muscular dystrophy. LDH will be very high in your malignancies. ANA, C3C4, and rheumatoid factor is for your connective tissue disease, and also rheumatological related problem. Okay, anti-double strand DNA, anti-SMID, anti-RNP, anti-RO, anti-LA is all very specific to the rheumatic problem, okay, or connective tissue disease. Okay, you send your X-rays or joint X-ray, chest X-ray. Enterocentesis, I think is the joint aspiration, and then you send for patient for ophthalmology examination to look for eye signs like uveitis. So the differential can be divided into inflammatory and non-inflammatory. So for inflammatory is your main thing, basically GIA. If any joint pain very chronic, we have to think about GIA first, especially if patient don't have any rashes. And then spondyloarthropathies, this one will involving your spine. So any back pain, any limited spine movement, limited range of movement, you have to think about this juvenile ankylosing spondylitis or seronegative enterocopathy. And on top of it is IBD. Psoriatic arthritis with very rashes, suggestive of psoriasis. Connective tissue disease, most important thing here is SLE. SLE, I wouldn't say it's very common, but you will see it from time to time. Juvenile dermatomyositis is the next one, followed by scleroderma. Okay, vasculitis, this one you have to pay attention lah. Your HSP is very common. This one is basically spot diagnosis. You see, you have to know the diagnosis. Kawasaki, another common one that can present with joint pain. Behçet yang Wegener granulomatosis and Takayasu arthritis. This one is quite uncommon. Okay. So non-inflammatory include your fibromyalgia, basically the pain involving your muscle, and then reflex sympathetic dystrophy, hypermobility syndrome. If patient have a very mobile joint, So mobile joint basically means unstable joint. Unstable joint mean a lot of movement. So they will have joint pain. And I don't know why it's growing pains. Okay. Alright, infectious. Infectious causes primary is bacteria, your viral and mycoplasma. Your post-infectious rheumatic fever. We have enteric fever as well and chlamydia. Malignancy include your leukemia. Leukemia also can present with rather than joint pain is limb pain because of if there is increased cell production in your marrow, it will stretch your bone marrow, it will stretch the capsule in the bone marrow, causing the bone pain. So it's more of bone pain rather than joint pain. Patient with neuroblastoma also will have joint pain, but this one also will have some neurological deficit. Patient with lymphoma and primary bone tumor lah, like example bone tumor in children, in teenagers. Yes, osteosarcoma and Ewing. Okay. Alright. Hematology, any hematological problem with joint pain? Have to remember the sickle cell as well. Okay. So orthopedic specific diagnosis like synovitis or capital femoral epiphysis. Okay, this one involving the growth plate. Okay. Alright. So trauma related infection like septic arthritis, osteomyelitis, TB and Lyme disease. So inflammation, as I said earlier, JIA or non-bacterial osteomyelitis. Tumor, your osteosuck or osteoma. Coagulopathy involving patient that will have coagulopathy causing hematosis. What kind of patient? Hemophilia. Okay. So hemophilia basically if got bleeding in the joint, you will have joint problem later on in life lah, because your blood is quite toxic to the joint surfaces. Alright. So orthopedic if patient have AVN, avascular necrosis, or patient have slip capital femoral epiphysis in the growth plate. Alright. So this one is a pain syndrome, CRPS. This one very painful condition. Okay. Alright. More differential is your JIA, SLE, juvenile dermatomyositis, HSP, and then chronic multifocal osteomyelitis and IBD. Okay, for infection, malignancy, don't forget the mechanical. If patient not very active, patient have very poor posture, patient is obese or overweight, they will have certain mechanical symptoms lah. Okay, and then on top of it, the pain syndrome lah. This one basically the diagnosis of exclusion. Alright, so ABC, what you want to see in the ABC, increased white cell will be suggestive of infection and malignancies, and also will be raised in systemic JIA and vasculitis. This be due to inflammation. Leukopenia can be post-infection, especially the virus. Neutrophilia will suggest of sepsis and systemic JIA. Lymphopenia is very common and very specific towards SLE. Hemolytic anemia also in SLE and also in mixed connective tissue disease. And CRP usually is normal in condition like scleroderma and dermatomyositis. Alright, so NA is anti-nuclear antibody. 30% of children will have positive NA, but we have no underlying problem. This can be induced by the infection. So if patient with relative, with parents, with siblings with rheumatic disease, this NA also will be increased lah. So infection screening to rule out infection like throat swab, to rule out ASOT that related to the rheumatic fever. Your urinalysis, the viral serology, CMV, EBV, parvovirus and hepatitis. Rheumatoid factor, it is very non-specific. It can be raised in many conditions, but it is significant if patient have more than 5 joint involvement. Okay, so it can exclude your oligoarticular JIA. JIA have many types. One of it is oligoarticular JIA. Another common one is polyarthritis JIA. Okay. So muscle, this one involving your muscular dystrophy, will be raised in dermatomyositis. We also will be raised in Duchenne, but can be normal also in dermatomyositis. very high LDH suggests malignancies. Okay, so you do X-rays to basically to exclude fractures and tumors. On top of it, you can see the joint space, if any, small joint space, if there is inflammatory process going on at the joint area. Okay. Alright, so what you see if you send joint aspiration for synovial fluid, in a normal, color will be colorless, very turbid, very minimal white cell count, less percentage of neutrophil, less than 35%. Glucose is almost equal to the blood. The culture will be negative. What differentiate inflammatory and infection is the color. Color inflammation will be yellow. Infection will be variable. Turbid is clear to turbid, but infection is very turbid. And white cell count will be more than 100 in infection, and it quite varies in inflammation. Neutrophil count can be more than 50, but if more than 75, more suggestive to infection. Glucose is low in inflammation, but somehow still low, but it's more than 2.8. Culture will be negative in the inflammation process, but often positive lah. But this one depends on the antibiotic and the timing of your joint aspiration. If you already give antibiotic for few doses, expect the culture will be sterile. Same like your lumbar puncture lah. Okay, but you will see certain biochemical changes that will remain even 1 week, 2 weeks after the antibiotics. Okay. Alright, so we're gonna talk about JIA. Out of inflammatory rheumatic disease in children, JIA is basically the most common. It's a chronic inflammation arthritis in children. So there are 7 distinct subtypes of JIA. As I said earlier, the oligoarthritis, less than 5 joints or single joint. Polyarthritis with positive rheumatoid factors, or polyarthritis with negative rheumatoid factors. Systemic arthritis, enthesis related arthritis, psoriatic arthritis, or undifferentiated. Okay. So the criteria for the classification of JIA, the age of onset usually less than 16 years old, and then there is arthritis signs including the swelling, if any effusion, presence of 2 or more of the following signs, including the limited ROM, the tenderness or pain on motion, or increase in heat in more than 1 joint. It must be more than 6 weeks, but the longer they are, the more likely they will have certain joint deformity. Okay. So onset type defined by the type of articular involvement in the first 6 months after the onset. Polyarthritis is more than equal to more 5 inflamed joint. Oligo less than 4 or equal to 4 joints. Okay. Systemic disease usually will have rash and also have characteristic coordination fever. Okay. This is one of the pattern of fever lah, you have to remember. Okay. Your other pattern of fever including your saddleback in dengue, and the malaria is what kind of pattern? Tak tahu. Okay. Alright. So JIA classification for systemic onset JIA same as said by the joint more than 1 at least, preceded with fever for at least 2 weeks in duration, documented to be daily coordination for at least 3 days, then accompanied with the evanescent erythematous rash. This rash will come and goes usually when the fever present, then the rash will appear. When the fever settle, the rash will go away. And also generalized lymph node enlargement if there is hepatomegaly or splenomegaly or both. On top of it, the serositis lah. It can be your pericarditis or pericardial effusion or pleural effusion. Okay. Exclusion. If patient has psoriasis or history of psoriasis, you cannot diagnose as systemic onset JIA. If also positive HLA-B27 positive, if there is ankylosing any vertebral involvement, okay, and then also presence of immunoglobulin rheumatoid factor in at least 2 occasions. Okay, this one not very important. Okay. ILA criteria for oligo, 1 to 4 joints for the first 6 months. The subcategory is the persistent oligo. The effect no more than 4 joints throughout the disease course. Mean is despite the treatment, the pain will still be present or just slightly improve. Okay, extended oligoarthritis, even that affect more than 4 joints after the first 6 months. Okay, alright. So it is the most common type of JIA, positive NA in 60 to 80%, and then higher risk of asymptomatic uveitis with positive NA. So even though patient don't have eye symptoms, you must send them for ophthalmology review, okay, to rule out uveitis. Okay, alright, this is the case of 4 years old presented with swollen joint at the interphalangeal joint for the past 4 months. Blood investigation show positive NA. Ophthalmic review reveal uveitis. So diagnosis is oligo JIA. So because joint involved is only interphalangeal joints. Okay, this is the coordination fever that I've mentioned earlier. So every how many days? This one also, if you see fever pattern like this, you must think about Kawasaki as well, especially if patient have rashes. Okay, so but this fever persistent throughout at least more than 2 weeks. Okay, but Kawasaki usually by 10 days they will resolve by itself. Okay, but despite Kawasaki resolve, they are at high risk of developing coronary artery aneurysm lah if untreated more than 10 days. Okay, this is the salmon colored rashes. It only appear when the fever comes. So you must, if you see the patient during patient fever, so you must ask during the fever got rashes or not. Okay. Okay. SLE. This is the malar rash. It spares the nasolabial fold here, and it spares the eyes as well. Okay. So it will have this kind of rash as well. Looks like kind of target lesion a bit. Alright. Okay. So connective tissue disease is SLE is a connective tissue disease. So you must have 4 out of 11 criteria. So the 11 criteria that are listed is the malar rash, discoid rash, any photosensitivity, any oral or nasal ulcer, any arthritis, any serositis, which is the pericardial effusion or pleural effusion lah. Okay, any renal involvement, so you must send the urine to look for proteinuria because they will have some degree of glomerulonephritis. So CNF involvement, it can be seizures, it can be psychosis. Hematology can be your MAHA, hemolytic anemia, it can be leukopenia, it can be lymphopenia or thrombocytopenia. So must have positive NA or must have any other positive immunology abnormalities like anti-double strand DNA, anti-Smith. LE preparation, basically the preparation, the investigation you send specific, basically the panel for SLE, basically all this part, anti-double strand, anti-Smith is part of the LE preparation lah. And on top of it, they will have false positive VDRL. Okay, VDRL we diagnose for what disease? Syphilis. Okay. Okay. So the pathogenesis of SLE is unknown. Can be genetic, it can be hormonal. A lot of hypotheses, but none are proven. It's very I wouldn't say it's very common, but in children and young adult, up to 6 in 1,000. Higher in African American and Asian and Hispanic and Native American. So female predominance. I've never seen the boys having SLE. Mostly, the one we diagnose is the girls. 9 out of 10 in reproductive years lah. So the young female most of the time. Okay. So children, the school going age, the primary school, then the teenage, you have to think about SLE. Yeah. Okay. The young one usually it's less common compared to that age. Okay. So often present with generalized fever, fatigue, weight loss, and non-specific organ dysfunction. Okay, so there is impairment in the white cell in your immunology cell, like your B cell and T cell. So that's why they're prone to infection, because they are leukopenic and lymphopenic. And then on top of it, B cell impact tolerance and increase autoreactivity, so they attack their own bodies. That's why they will have inflammation anywhere. So most of the time it's a systemic involvement lah. Okay, so there will be increase in memory T cell and decreased number and function of the regulatory cells in SLE. Okay, so this is the organ. The systemic involvement, basically all system can be involved, but out of this one, I would say the most common one is your skin, your MSK, the joint, your kidney, and then your hematology. Okay, I think this is the top 4, and then followed by your cardiovascular, then neurology, and then GI, and on top of it constitutional symptom as well. Okay, alright. So for constitutional symptom, fatigue, anorexia, weight loss, fever, and lymph nodes. Your musculoskeletal, the arthritis, can be the muscle as well, myositis, tendon, arthralgia, myalgias, and osteoporosis. Rashes, photosensitive rashes, cannot go under the sun. They will have rashes if they are exposed to the sun. Livedo reticularis, the certain pattern of the rashes on the skin. Periangual capillary abnormalities, they can have Raynaud's phenomenon as well, and also alopecia and oral and nasal ulcer. This is all part of the skin manifestation. So for renal, for kidney, they will have hypertension. So the nephrotic syndrome in SLE, they can present as nephrotic syndrome as the first presentation. Okay, for SLE. So a patient come with massive proteinuria, but there is atypical features like hypertension. That one you cannot say it's a minimal change disease, nephropathic syndrome. You have to think about SLE lah. One of the patient that I diagnosed when I was in Sungai Petani, it present with nephrotic syndrome. Then on top of it, the most prominent features that patient had was hypertension. BP always on the high side. Okay, and then the rest is hematuria, edema, and renal failures as well. Okay, so cardiovascular, they will have pericardial effusion or pericarditis symptoms, myocarditis as well. Okay, and then conduction system abnormalities. So for conduction system abnormalities in children, especially if mother has underlying problem, if mother have anti-Rho or anti-La positive, the babies can be affected. They can present with heart block, congenital heart block. Okay, this one is in the neonate punya population. Okay, alright. So for neurology, psychosis, seizures can be present with stroke, can present with tremulous myelitis and depression as well. Okay, so pulmonary involving your pleura. So if patient with massive pericardial effusion, you have to think about SLE as well. Okay, hematology, quite common. Mostly we seen the thrombocytopenia and leukopenia and lymphopenia. Okay, so hepatosplenomegaly in GI, pancreatitis, and then protein losing enteropathy. So the eye, as we have mentioned many times, which is your vasculitis, uveitis, and scleritis, and episcleritis as well. Alright, so the diagnosis, anti-double strand DNA is not very specific to the SLE, but it correlates to disease activity. If patient still positive, mean the disease is still active, mean you're not controlling the inflammation well enough. Anti-Smith is very specific for diagnosis of SLE. Anti-RMP antibody, if positive, patient have increased risk of Raynaud's phenomenon. On top of it, pulmonary hypertension. Anti-Rho and anti-La can be suggestive of Sjögren's syndrome, can be suggestive of Zika syndrome, and on top, as I said earlier, increased risk of neonatal lupus in the babies. Okay, if mother have these two antibody positive, patient can have congenital heart block. Okay, if the disease is not well controlled lah. So if patient with mother with anterolateral, we usually monitor them in the NICU for heart block. We do ECG. If patient already diagnosed with heart block intrapartum during antenatal, means when they do the antenatal scan, the heart rate, usually baby's heart rate usually how much? 100 to 150 lah, fetal around that region. So babies will be heart rate of 50, even slower than you all. Okay, so this kind of patient will need pacemaker from birth. Okay, so antiphospholipid antibodies is quite commonly sent in mothers, pregnant mothers. If patient on pregnant mothers that have antiphospholipid antibodies positive, they are at risk for venous and arterial thrombotic event. So most of them patient will be on aspirin lah. Okay. Another uncommon one is antihistamine antibodies lah, present in majority of patient with drug-induced lupus, but can be present in SLE as well. Okay, juvenile dermatomyositis. How we differentiate juvenile dermatomyositis to JIA is the rashes as well. This is the heliotrope rash that I've talked about. Okay, this is the periangular capillary rashes. Okay, so presentation violaceous heliotropic rash, have proximal muscle weakness. So Gower sign can be present, so it's not very specific to Duchenne, because Gower sign only tell you patient have proximal muscle weakness. That's all. Okay, so arthritis and also dysphagia and dysphonia. Gauthron's papules, bright pink and pale, shiny, thickened atrophic plaque over the PIP and DIP lah. On top of it, patient will have lipodystrophy, calcinosis and telangiectasia, and we have extreme photosensitivity lah. So they will have erythema over the chest or neck shawl sign lah, mean the area your neck punya t-shirt punya area tu, they will have rashes in that region. Okay. The JIA usually don't have muscle tenderness. So half of the patient with juvenile dermatomyositis will have muscle tenderness because there is myositis, so your CK will be raised, muscle enzyme including your AST lah, and then we'll have abnormal muscle biopsy lah. Most of it will be inflammatory changes lah in the muscle biopsy results. Okay, this is the Gauthron papules. See, it's like a plaque, but it's not really peeling like psoriasis. Okay, and very specific region at the joint, at the PIP, and then the distal one as well. Okay, so the diagnosis need to have this classic rashes, heliotrope rash over the eyelids and Gauthron papules, plus the weakness or muscle enzyme elevation, EMG changes that indicate myopathy and denervation, and myopathy will show inflammation and necrosis. Okay, this is HSP lah. Most of the HSP will present with rashes like this. So that's why I said when you see rashes like this, you must think of HSP first. But meningococemia also will be something like this as well lah. But meningococemia will be more purple lah. This one still a bit on the red side. Alright, HSP is basically your vasculitis involving the small vessel. It's IgA mediated. Mostly affect the boys, but the girls also we see. The triad of symptom is sign is arthritis, abdominal pain, and palpable papular purpurate rash. Okay, abdominal pain is because of the inflammation of your mesenteric artery vessel or small vessels in your small bowel. Okay, so investigation you send the ABC, renal function and urine dipstick, because if involve the small vessel, your capillaries, so kidney also have a lot of capillaries, right? Your nephrons is basically built up from capillaries, so you will have so it can be one big cervical lymph node as well, and it can be diffuse cervical lymph node involvement as well. Okay, so on top of it, they are very irritable, Why patient with Kawasaki irritable? In what other diagnosis patient also irritable, crying non-stop? Meningitis lah. So in KD they will have meningitis by the aseptic meningitis. If you do LP, there will be no growth from the culture. Okay, as I said, sterile pyuria, sterile meningitis, inflammation of the meninges lah. So they very irritable. Perianal erythema is part of your involvement in the lips and oral cavity lah, your mucosa involvement lah, because perianal there is mucosa area and then your skin area, so the one that become red is the mucosa area lah. So perianal erythema mostly involve the young children. The big children, they will not have these symptoms. Sterile pyuria, because inflammation of your bladder, your kidney, they will have increase in the white cell count, but you send the culture will be negative. And then on top of it, they will have hepatic and renal involvement and GI dysfunction. But more common is myocarditis. Patient can have myocarditis. They will have dilated cardiomyopathy. On top of it, tachycardia as well. If you do ECG, all those myocarditis changes, and then pericarditis as well. Okay. So other features that can be present that not mentioned here is your BCG. Anything? BCG flare. Okay. Alright. So investigation that we send is your FBC to see any increased white cell and CRP. Usually CRP will be very raised, more than 40 most of the time. Thrombocytosis only happen at the later stage, at the second week, and then it peaks at the third and fourth week. SR you also increase and then will return normal in 1 to 2 months. Hepatitis will show increase in transaminases and hypoalbuminemia. More severe the Kawasaki, the lower the albumin. Then echo will show aneurysm lah, if there is aneurysm. Usually can be seen from first week up to 21 days. So as long as the inflammation is ongoing, more likelihood the aneurysm will develop later on. Okay. So how do we treat? So the keyword here is high dose. Okay. So high dose is 2 gram per kilo. Anything less than that is not high dose. IVIG also used in a lot of condition. If patient in sepsis, we give 0.8. Patient for ITP, 0.8 gram per kilo. So it's much lower dose compared to the KD IVIG dose, which is 2 gram per kilo. And on top of it, we give aspirin. Aspirin also, there are 2 doses. High dose aspirin and then antiplatelet dose, which is the low dose aspirin. High dose is for anti-inflammatory, usually in the first 2 weeks of disease. Some center will treat until the fever settle with the anti-inflammatory dose, but when the fever settle, they will change to antiplatelet dose. But some center will keep the anti-inflammatory dose up to 2 weeks until the appointment when they see patient again. Okay, so 80% of patient will respond to aspirin and IVIG. So some 20% will need second dose of IVIG, maybe sometime third dose. But if second dose also not responsive, we will give IV methotrexate, which is your corticosteroid. Some give methotrexate, some just give oral steroid as well. Okay, there are a few other treatments, including your infliximab lah, but I have never used it myself before. Okay, most of the time they will respond up to the steroid level lah. Okay, alright. So this is basically the Japanese scoring to predict IVIG resistance lah. So there are a lot of scoring. The Japanese one are Igami, Kobayashi Sano. This is not very important, but this one very specific to Japanese punya population lah. As you can see, about 80 to 70 punya percent sensitivity and specificity. But when you test in non-Japanese cases, it's not very sensitive lah. This was my thesis during my master For Malaysian population, same result as well. It's not very specific and sensitive for Malaysian population as well. Okay. Alright. Yeah, done. Any question? Any question? Anything? Alright. So out of all these problems, yeah, must know Kawasaki very well, or HSP very well, and then JIA lah, and plus minus your SLE. Alright. Okay. If no question, we end here.